So I'm going to talk to you about point of care or bedside ultrasound to guide shock care. Okay, only major disclosure is that I've drank the Kool-Aid. I believe in the merits of point of care ultrasound, so you hear that bias all throughout the remainder of this talk. However, I do believe that ultrasound should not live inside of a bubble. You've got to take into consideration the history taking, the physical examination, the laboratory data that you have at your disposal, any other imaging studies as well, and put that all together for integrating for a clinical practice, okay? So it does not live in a bubble, so just keep that in mind with everything else that I'm talking about. Now, there's lots of different ultrasound shock protocols that have been published in the last 10 to 15 years' time. And more than just, again, we're trying to go to an individualized approach. So I'm not going to just regurgitate, some of these protocols that have been done in the past. But I think more, I want you to think thoughtfully about your approach and ask yourself, what questions are you actually asking yourself as you're engaged with patients who have kind of more undifferentiated shock states? And so you'll see that a lot of these different protocols have similarities. You're looking at the heart, the IVC, you're looking at the lungs in different ways, either to corroborate your findings that you're finding on echo, or to look for things that could be signs of extrinsic compression around the heart, or RV issues that could lead to then pulmonary pathology that could lead to RV issues, DVTs as signs of vascular disease as well. So this is kind of where your headspace should be in. So, if you're trying to understand the shock state, the way my primitive mind thinks is, well, is it cardiogenic shock, like systolic dysfunction, valvular issues, i.e. blame the heart? Or is it a situation where we have obstructive shock where, it's either in the vessels or it's extrinsic compression, and so i.e. don't blame the heart? Then you have hypovolemic shock, which is typically in our world hemorrhagic shock, though David was talking about cholera, and I guess unless they're peeing like a racehorse or having diarrhea or just ran a marathon, probably not in hypovolemic shock from just loss of fluids. It's probably more from hemorrhagic shock. So in this case, don't blame the blood vessels. There's not enough inside of there. And then you have distributive shock, which in our world, other than the adrenal, neurogenic, and so forth, is typically septic shock. And so in this case, we have vasoplegia, and you can kind of blame the blood vessels. And so this is how I think about things, is who to blame when it comes to shock states. So let's start off with cardiogenic shock. So a lot of the common ways you're going to look at it is going to be in the peristernal long axis view. It's a great look to see what's happening in the RVOT, particularly proximally. You can see the interventricular septum that's there and see if there's a pressure or volume overload state there. You can see contractility of the LV. You can see pericardial effusions. You can see what's happening with the valves, and if there's valvular regurgitation that's happening as well. You can look at the anterior septal leaflet of the mitral valve and see if it's smacking the interventricular septum. As e-point septal separation. On a peristernal short axis view, you can see the relative influence of the RV on the LV. You can look for wall motion abnormalities as well here. You can look at the mid-ventricle, defined as the papillary muscle level, and see the type of squeeze and contractility that's there. So right here, we have a normal peristernal long axis view. You can see how that septal leaflet here is just smacking the interventricular septum right there. The RVOT looks nice and ovaloid in shape. You have nice squeeze of the LV. And similarly, in peristernal short axis view, you can see that the LV, the interventricular septum, is nicely rounded. It's part of the LV squeezing in time. The RV is very thin walled, and you can't really make it out as well as it sits right behind the sternum. With the apical four-chamber view, it's a great place to look at, again, valves, but also relative ratios of RV to LV, also more of the interventricular septum as well, and then the atria. Your subcostal long axis or subxiphoid view is a great place to look, using the liver as your acoustic window to be able to see the right heart and the left heart. Again, you can see some relative sizes of RV to LV. You can see things like contractility with RA and RV. You can see pericardial effusions as well. So these are, and of course, valvular dysfunction. Typically, when we're thinking about the RV side of things, RV should be less than 2/3 the size of the LV, does not share the apex. That's normal. If you see the RV that looks similar in shape or size to the LV, then you have moderate RV dilation. And now it's starting to share the apex of the heart. And in severe RV dilation, you start to have an RV that's larger in size than the LV size, and it forms the apex of the heart. You can also look at RV functionality through like TAPSE, which is recommended by American Society of Echocardiography. And you can see that normally there's longitudinal shortening of the RV free wall. That's how it makes its ejection fraction. And you can see the distance that it moves towards the apex there, and then you can look at the TAPSE. It has good correlation with kind of RV ejection fraction. Typically, in the latest kind of normative studies, take a cut point of kind of less than 15 millimeters for men and women to be abnormal in terms of a TAPSE. So you're looking for RV dysfunction. The subcostal view, you can see that longitudinal shortening, the RV, the tricuspid annulus moving towards the apex. You can see that the RV tends to be a little bit foreshortened in size comparatively. You can see relative ratios of RV to LV and any type of pericardial effusion that's around there. In cardiogenic shock, when you have systolic dysfunction, you're going to see that anterior septal leaflet does not hit it's a greater than 7 millimeter distance separating the two. If you were looking on M mode, you're going to see contractility that's diminished over there as well. Over here in the parasternal short axis view, you can make out and see that that squeeze is impaired. The more you look at it, the more you're going to recognize. And at the very least, learning to view it kind of qualitatively in kind of a mild, moderate, severe dysfunction state is, I think, useful. Over here, we have a swan in place, and you can again see in the apical four-chamber view, you can see how the valves are opening here on the mitral side of things and how poor the contractility is of the LV. If we were to tilt this and make this into a apical five-chamber view, you could put a pulse wave Doppler right here, and you could measure a VTI. VTI, I think, is very useful in terms of normal being about 18 to 22. It's really a manifestation of the stroke distance. And then if you multiply it by pi r squared, which is the area of the LVOT outflow tract, then you'll get the stroke volume. But generally, that pi r squared area stays fixed. And so you can really use VTI as a surrogate for stroke volume. I find it useful in seeing change, whether it be with volume resuscitation, passive leg raise, inotropy. You can look for changes in VTI over time. And then subcostal view, you can again see the contractility. Sometimes this is your only view that you can see when patients are undergoing chest compressions, or if there's a lot of air in the way, if you're not going to use TEE. And always, pair this with a lung pleural ultrasound. If trying to see, are there B lines that are emanating suggestive of an alveolar interstitial syndrome? Typically, what's happening here is that you have a release with pulmonary edema, a smooth kind of pleural line. You have these B lines, which are starting from the pleural line and going all the way down your screen, laser-like focus. And again, so it has an alveolar interstitial syndrome, and you can see if it's concomitant in the left and right lungs. Also, if there's a gradient in terms of dependency. Valvular dysfunction, I don't really have time to go into it in this regard, but every time you see valves, put a color Doppler box on it, and you can see the amount of regurgitation through there. And I think that's a very helpful thing, particularly when you're calculating things like PASP and other things. You can kind of utilize that, and you can use it in multiple different views. If we move into obstructive shock, so quick case, 70-year-old, no past medical history, came to our orthopedic hospital post ankle fracture, shortness of breath of 3 days, no really other signs, and then had some intermittent dizziness, no loss of consciousness. Initially, on exam, they had apparently a popliteal DVT here that you can see. It actually extended all the way to the common femoral vein level. And then over time, they were started on anticoagulation and they decompensated. And so here's their cardiac examination. So parasternal long axis view, you can see that the RVOT now is gone from its ovaloid shape to a more rounded basketball shape. You can also see that the LV cavity is quite small in nature as well. And you have some bouncing of the intraventricular septum. When we go over from there and we go to our parasternal short axis view, we see a clot in transit inside of the RV. You can see the RV is pushing down. So it's a pressure overload state and creating a D sign, where if on the LV, you can see that all throughout the cardiac cycle, whether it be systole or diastole, that the LV is not returning to a nice circular shape. And so this is a pressure overload state that we have here. And again, ventricular interdependency, so that the LV is going to be underfilled. Here we have the apical four-chamber view. You can see the moderator band going across in the RV. Of course, we have this little child that's trying to get your attention doing backflips in the right atrium. But you can also see that in terms of a TAPSE, that the tricuspid annulus is just doing a little shoulder shrug. It's not really moving towards the apex very well. You can also see that at the apex of the heart, there's some more increased contractility, but not really at that mid level in the RV. So this is what's referred to as McConnell sign. And then the subcostal view over here, we can see the clot that's trying to get into the RV side. But the main thing we see is that the RV is quite dilated and the LV is small and the cavity size is compromised as well because of that ventricular interdependency. And so in this case, this individual had a massive PE clot in transit that you saw in the RA, common femoral vein DVT that extended all the way down to the popliteal vein, and severe RV RA dilation with pressure overload. And so, that's one form of structure shock happening inside in terms of blood vessels, but the other one could be mechanical and extrinsic compression. So typically we're looking at the lungs. So we're looking at, normally we see normal lung sliding at the pleural line. Compare that with on the right side where we have movement, but not a shimmering, ants marching on, type of appearance there. We do have an A1 line here, and that's about it. So, and then if with that, you always want to kind of move laterally and try and look for a lung point, which you're finding here. And oftentimes when it's hemodynamically significant, you might have a very large pneumothorax where you're not going to find actually the lung point that's there. So keep that in mind. Pericardial tamponade is another way. Now, in this case, we're moving a little bit closer to the heart, and now there could be fluid inside of the space. In this case, it's kind of fibrinous. So you want to look at the amount of fluid that's there, but also the texture, ecotexture of that as well. You can see that that's compromising the contractility. Generally, what you're looking for is early systolic collapse of the RV. The right atrium, and diastolic collapse ultimately of the RV side is what you're looking for. And the other ways you can look at for pericardial tamponade is look at inflow pattern. So you can look at the ventricular velocities on inflow. For mitral inflow, you're looking for a 25% or greater decrease with respiraphasics. Compare that to about 40% decrease with tricuspid. So hypovolemic and specifically hemorrhagic shock. So the idea is that, things like a fast exam, you're looking for really free fluid, right? So you're going to look in the abdomen. You're going to look around the kind of hepatorenal recess area, Morrison's pouch over here that we're seeing the liver and the kidney. And then you can see fluid that's tracking into kind of around the liver and into Morrison's pouch. You can also have fluid on the other side, which you have the spleen. It's going to go around the spleen because you do have a splenorenal ligament that holds the two together. But otherwise, you're looking for free fluid around there that should not be there. Sometimes it's difficult because a lot of patients have ascites and you may have to sample it to be able to see. Here we have the kind of fluid around the bladder and bladder space as well. Again, thinking that things might settle in the peritoneum first and then come up into the abdomen. Pleural effusion is another good place. I had a patient on ECMO on therapeutic on anticoagulation, and they had this type of imaging. And on here, you can see kind of things swirling around this inside of it. So very high ecotexture inside of that pleural space. And they had a hemothorax that had developed. And so this is called hematocrit sign. So looking around for where bleeding could potentially be occurring is very important when you're dealing with hypovolemic hemorrhagic shock. Moving on to septic shock. So oftentimes with septic shock, you're dealing with somebody who's either normal in terms of cardiac functionality or else it's hyperdynamic. And so you're seeing imperisternal long axis fuse, short axis fuse. You can see that qualitatively that, that kind of increased squeeze contractility that you're seeing there. Technical approach, really what you're using ultrasound for when it comes to septic shock is primarily, one is of course fluid responsiveness, but the other one is source location, right? And so you're going to look in areas like the lung, and you're going to look for kind of the lung parenchyma, but also for the pleural fluid as well. Heart, you can look for valvular vegetations. Abdomen, you can look at the gallbladder. Liver, I found multiple liver abscesses over time, and also into the muscles, joints, and skin and soft tissue. Cellulitis, you can see cobblestoning, neck fast, subcutaneous thickening, air, fascial fluid as well. And so, putting a probe on it is probably the most important thing. Here we have focused echo, and you can see on the mitral valve, you see that thing kind of going back and forth, and it's a vegetation that's there. And you can see that also here in the apical 4 chamber view, so there's something going in and out along that valve. And so that's a vegetation that's there. Then we have things like source identification in the lungs. You can see the kind of fractal or shred sign. You can see the pleura is being broken down, and it's because right under it, we have a subpleural consolidation that's there. on the picture on the right on the top, making sure that you fan all the way through the pleural space when you're looking for septations. And then in this case, so you see septations are very thick and echogenic in the center. And so kind of sampling these things, clearing out that source is very important. And again, can be diagnosed right at the bedside. Abdominal ascites. I had a patient in cardiogenic shock whose lactates went into the double digits. And I said, maybe they're going into compartment syndrome. There's a lot of ascites there. We took fluid out. And then it turned out that, yes, indeed, it kind of purulent material came out of there. And they ended up opening up the abdomen, washing it out, and his lactates came back down. Gallbladder. Gallbladder is another place that you can see the thickened wall and that kind of stone that's there. And it's causing, that stone is causing a shadowing effect posteriorly as well. So looking at the gallbladder is very important, thickened wall here. And then for those kind of who want to put it for summative, summatively putting things together, some people are less visual and more kind of, I would say, tabular in nature. And so thinking about it is that if you're in things like distributive shock, in general, your heart's trying to compensate with that. You might be tachycardic and more contractile, and so your VTI is going to be high. Your IVC may still be small, and then you're going to be looking in a distributive shock picture for the sources for where that's coming from, pneumonia or other location points as well. When you're hypovolemic, as you can imagine, it's going to be low because your stroke volume is low, and that's going to be the same thing you're going to see in cardiogenic shock. The difference is their IVC is likely going to be large when it's come to cardiogenic shock. And then you're looking for sources of bleeding in the hypovolemic shock individual. Cardiogenic, you also have to look at the valves and then obstructive shock. You think about PE, tamponade, and pneumothorax. And so you're going to look for those specific findings. And again, you're going to have a low VTI in that setting, large IVC, plethoric in nature. And then you're looking for the etiology, as we kind of talked about. And so take-home points I have for you to end this is, one, really advocating for a multi-system focused evaluation. Of course, you can get into a habit of doing the same things over and over again, but I really try and be thoughtful in my approach about what's happening with the patient. What do I know about them? What am I seeing on physical examination? And then going and targeting those systems systematically to keep giving myself more information. Focused cardiac echo is a really good place to start when it comes to undifferentiated shock, but pair it with your lung, pleural, abdominal, and vascular ultrasound. That's my problem with some of the protocols, is that they don't always have all the other aspects that are additional to their protocol. And the other thing is we're creatures of habit and pattern recognition. The more we do this, the more you're going to recognize things and get faster in speed with it. You're going to become better at image acquisition, image interpretation, and then the clinical integration part. And then lastly is that POC assessment of shock must be integrated with all the data at your disposal to guide clinical decision-making. And just a smattering of some references I used, particularly for some imaging and others. And then with that, I'm going to end the talk. So whirlwind tour. So I talked fast and showed you things really quickly.